Hello, everybody. My name is Dr. Fermin Barrueto. I am the Chief Clinical Officer for CoreLife, and I will be talking to you today about precision medicine and how Dr. Acosta and his team came up with the phenotypes of obesity. So, I think everyone is beginning to recognize that obesity is a chronic and multifactorial disease state that can impact over 280 comorbidities and has high variability in treatment response. A one-size-fits-all approach is simply inadequate. Dr. Costa and his researchers went from observational studies, questionnaires, and eventually genotyping to be able to come up with what was initially 11 different phenotypes and actually have gotten it down now to 4 different phenotypes by looking at the energy expenditure, the intake, the behavioral aspects, and metabolic aspects of obesity. So the 4 traits that they came up with, the 4 phenotypes: hungry brain, think about food, can't seem to get full; hungry gut, these are the people that don't feel full, that they keep eating and are able to keep eating but don't get full. Emotional eater, these are the people that I eat when I'm mad, I eat when I'm sad. And then you have the slow burners, and this is all related to energy expenditure. Each of these phenotypes were validated with both physiology and clinical outcomes, which we're going to touch on here briefly. The hungry gut phenotype. It's actually initiated by the accelerated gastric emptying, one of the things that I thought was fascinating, and you can prove this by just looking at some of the research studies on your own. When you look at the semaglutide or tirzepatide data, it is presented as average weight loss. What we don't get to see very in a detailed fashion is the actual almost bell-shaped curve response to the GLP-1s. There are people that have no response. There are people that have an average response and those that have an exaggerated response, upwards of 30% total body weight loss. So when we look at that in a controlled research setting, then we know for a fact that there is variability in response to GLP-1s. All of you have seen this in the clinics, but then we question, is it because of compliance? Is it because of when they take it or their diet? They also ended up looking at the diet strategies to slow gastric emptying and found some incredible results when they were able to isolate the phenotype to a pharmacotherapy and to a diet. When you talk about hungry brain phenotype, now this one, you can't get more definitive here with a functional MRI, and we're going to show you some of those pictures here, but essentially these phenotypes require a higher caloric intake to feel full. They respond to appetite regulating therapy, and we're going to go into pharmacotherapy here that helps out this particular phenotype. But in this functional MRI, it highlights the areas that are controlling satiety and hunger in the hypothalamus. And amazingly enough, they show there's an increased blood flow to the hungry brain, and non-hungry brain phenotypes have a lower blood flow. So as you can see, each of the patients that we take care of have different phenotypes, different impact by the different therapies that we actually provide them. Emotional eater. So these people have a very prominent hedonic, reward-driven eating. It responds incredibly well to cognitive behavioral therapy, and in particular, one drug, bupropion naltrexone or Contrave, seems to have a much better effect on this phenotype. The slow burn phenotype. This is where there's low resting energy expenditure. These people tend to benefit from high intensity interval training and resistance training, and can also benefit from protein supplementation. So we went into the 4 different phenotypes, but what is the actual evidence behind this to say that this is actually viable? Well, there's been a tremendous amount of research that both Acosta and some of his other fellow colleagues have worked on. And they essentially, in double-blind controlled trials, showed that phenotype-guided pharmacotherapy, 79% of the responders were responding versus 34% with standard care. So responders had 10% total body weight loss at 12 months. And if everybody remembers, 5% is considered physiologic benefit. And at 10%, we really begin to see even the structural issues related to obesity, like obstructive sleep apnea, begin to improve. So, of course, the GLP-1, one of the most expensive medications. What if we were able to target or know who would respond more or better when we institute this therapy versus another? And can we attain the same weight loss with a lower cost medication, such as phentermine? So for hungry gut positive people with hungry gut positive genotypes, they were almost at a 20% weight loss at 12 months, even better than what you saw in some of your studies with regards to semaglutide. The hungry gut negative people had literally almost half the response with a 10% total body weight loss. So could we get to that same weight loss in that patient population with a lower cost drug is the question that now we're beginning to ask. What about diets? Well, this one was really surprising to me, I have to admit, and impressed. They were phenotype diets. Now, they didn't come up with new diets. They utilized the same diets that are out there and just adapted them to the different phenotypes. This was a 12-week study, and they did this versus the Mayo Clinic diet, which was applied to everybody, and they saw significant improvement in total body weight loss, specifically with essentially attenuating the volumetric and high fiber and protein content in the diet. So as you see here, again, almost a 2x difference. The bottom line is your weight loss with those that actually had phenotype-specific diets versus those that did not and just had the same diet across the board, showing that precision medicine impacts even the diet effectiveness as well as pharmacotherapy. Biomarkers. So how did they actually do this? Now, this is the part that it's great to hear, but maybe not directly applicable to what we're able to do in the clinic. Maybe. So what they did is they were able to identify about 41 different genes, utilized machine learning, and went through a variety of studies and patients to essentially get an R-square that was strong enough, 0.55, where they were able to essentially map the genes that were associated with obesity with the particular phenotype of satiation. So they were able to get this R-square correlation strong enough, and then were able to show genotype led to phenotype, thus creating a blood test for a phenotype of obesity. In this particular case, hungry brain. So it's amazing, but we can do this on our own in the clinics without the blood test. Maybe not as accurate, but if you can evaluate and talk to your patients, you might be able to identify that phenotype and select a better medication that will have a better impact or a better outcome for your patient. So what's the system impact? Well, I already showed you both diet and I showed you pharmacotherapy that was almost 2x better than when you just applied it to all your patients. If I told you that there was a method in which you could actually double or improve your outcomes in such a way, I think all of us would jump up and down for it. You're able to reduce treatment failures, thus you're reducing overall treatment time, and you're able to optimize the expensive therapies. And then what's most important to all of us as physicians, we're actually able to improve their metabolic function. You're improving their hemoglobin A1C, their blood pressure. For hospitals and health systems, you're reducing length of stay and readmissions. Or for that matter, hospital-acquired infections. Go down the list of all of the different obesity, comorbid conditions that improve with weight loss. Very significant, very exciting information. Here at CoreLife, we integrate all 4 pillars: medical, nutrition, exercise, and behavioral, and we tailor our therapies to the patient. Not every patient gets all 4 pillars, and we meet the patient where they are. And we are looking towards making sure that we optimize our outcomes here at CoreLife. I hope you enjoy. Feel free to email me at my CoreLife email there, as well as my cell phone. I love to hear about cases and patients and happy to help you out. I'm also boarded in medical toxicology, so of course pharmacotherapy is a particular love of mine. And happy to help you out in any tough cases you may have. And remember about the phenotypes of obesity.